I'm Dr. Amanda, orthodontist at StraightSmile Solutions. We help dentists launch and scale orthodontics in their practice. Today, we'll be sharing some content from a webinar that was co-hosted with Ms. Tamara Thomas of Facial Physique Oral Myofunctional Therapy. To connect with Ms. Thomas, please use this QR code or visit www.facialphysique.com. If you want to help with an orthodontics case, please contact Dr. Amanda with @StraightSmile Solutions, www.straightsmilesolutions.com, or click on her QR code.
So I put this QR code. I don't know if this would be super helpful because what it's going to do is it's going to take you to a screening tool that you can utilize. And I'd be happy to email it to anybody if this isn't working correctly. But it's called the Fairest 6. This was, I believe this is Dr. Zaghi. He's an ear, nose, and throat physician who does a lot of research for how myofunctional therapy fits into craniofacial growth, how it's effective, kind of doing the research behind all of it. And it's a 6 red flags for sleep disordered breeds. So I give this to everybody when I go into a lunch and learn at offices. And it's a quick screening tool. So it makes it really nice because I know in the busy day, you're like, I don't want one more thing to add to my plate. So
That's
you
awesome.
Basically just, just go through and check, do they have this? Do they have that? So do they nasal breathe or do they mouth breathe? Are they lips together? And even like right here, I was explaining that mentalis strain. If the lips are weak, they have a lip seal, but they're compensating. They're getting that mentalis to really compensate. And that's an indication that the tongue's not on the roof of the mouth and that they're not using those muscles correctly. And then you can look at the tonsil scoring system. So if they have less than 50%, more than 50%, if they have ankyloglossia, and that one, actually this one goes into here on the right-hand side, and they develop this one as well. So you can have the patient open wide. This is a tongue range of motion ratio. So you want them to open wide and stick their tongue to the roof of the mouth without closing. You want them to stay nice and open. If they're able to reach completely without closing, that's a grade 1 or 80% or more. If they're not able to go quite the 100% or 50 to 80%, that's grade 2. Grade 3 is 50% or less, or 25 to 50%. And then 25% or less is grade 4.
Oh, I think I have a tongue tie. I just tried it.
You tried it? Which one are you?
Bad. I'll have to show you when we're
Let's see.
Oh no. Okay. We'll get to that later.
This is very common for patients, or even not patients, but workers. When I go into dental offices and other offices, they're like, wait a second, let me try this. Wait, I can't do that. So it's pretty eye-opening.
Fascinating.
But the tip one, the first one on the right or the left-hand side here, this is just the range of motion with the tip of the tongue. Now we got to look at the back of the tongue as well, because a lot of patients will have plenty of range of motion with the tip of the tongue, but that back of the tongue is too tight to the floor of the mouth. And so the two together is really what is gonna not diagnose a tongue tie. It's really just a tool to kind of see where there may be an issue going on. So if you go to the lingual palatal suction, the LPS, we want you to be able to suction the tongue up, opening wide, but we also want you to have what we call deep caves. And that means the back part of the tongue is suction up and the fingers can kind of go deep inside. If you look at this grade 2, they don't quite have deep caves on either side. So a lot of times patients can't even suction their tongue up at all. Like I can't keep it up there. So we usually go through therapy with myofunctional therapy, a couple sessions before they can even accomplish this, but it'll give you an idea. So if they can open wide with a suction, and it can be about 60% of their complete opening width, then that's a grade 1, grade 2, 30 to 60. 30% is grade 3. And if they can barely do 5% or unable, that's a grade 4.
Quick question. It says here for pediatric SDB, could you use the same type of screening for adults, or is it different?
Yeah. Yes.
Okay.
Mm-hmm. Yeah. I'm not sure why they only say pediatric, but we use this for both adults and children. A lot of times this part can be very difficult with kiddos because they're little.
Yeah.
So then we look at other compensations, watching them drink, watching them eat, seeing what other facial muscles that they're utilizing that they shouldn't be utilizing. So it could be a bit different. It just depends on the patient and what they're able to do.
Cool.
Then the next one is also that dental wear, like I was just saying, my dad has. Do they have some incisive wear or occlusal wear on the posterior teeth? If that's a yes. And then also, do they have a really narrow palate, or is it a nice wide palate? Do they have crowding of the teeth? That's an indication that that tongue's not at the roof of the mouth. And then based on this, you can do the scoring of severity. So if all 6, that's pretty severe. If they have nothing, then they're good. If they have 0, then no need to refer.
Now, question regarding the intercanine and intermolar distance. I do that a lot with my doctors. I have them measure, but it's going to be different in a kid than as an adult, assuming they have their 6s or their first molars in. You're measuring from the first molars, and you're measuring from the CEJ or from a cusp tip, or where are you measuring from for intermolar?
Yeah. Mesial buccal cusp.
Mesial buccal cusp. Oh, really? Okay. See, I measure from mesial palatal cusp tip is how I teach my doctors, but all different ways to do it. So
yeah.
Okay, interesting. Those are definitely smaller numbers than, maxillary. Oh, I see. 52. Okay, that makes sense then, because I say 40, but I do mesial palatal. If doctors have heard me lecture, so it basically will turn out to be the same thing. Got it.
Right. Okay. Yeah, just a different landmark.
Got it. Intercanine distance. Okay, that's what I get for not reading first. Okay, thank you. Go ahead.
Good question.
Yes.
Yeah, so it's just a little cheat sheet that I think is kind of handy to have. And obviously you don't have to have this with every patient. Once you get to know it, it's really simple. So yeah, if you want, there's other forms that you can download at ferris.org. Really good place to go. The QR code I gave you was just a link to this particular document, but if you go to ferris.org, you'll be able to see other screening tools that they utilize.
Ferris.org. Okay, functional airway evaluation screening tool. Got it.
Yeah, it's very, very friendly, user-friendly, and it's all here.
Is there like a printout that you can print out, like if you wanted to send it home with your patient or something like that? I'm assuming it's copyrighted, but can you print it out and use it?
Yes. So they're so nice to have been able to make this readily available for everybody. They're trying to get the field, everybody at kind of a standardization, so we can all discuss and see what we see.
I love it.
Everything. So it's super nice. I print this out all the time. I put it on, actually, I laminate it for any dentist that I go in, or I can send a laminated copy if anybody wants that. I'm more than happy to do that as well. But it's a good tool to keep in hand. So a little bit of why you may be thinking, like, why do I need this for patients? How does this pertain to me? So main thing is, with pediatric dentists in general, it's a good, like I said, a good time to start screening those kiddos, because you can really make an impact in their growth and their airway, which if they develop sleep disordered breathing, it can be very, very difficult to function during the day. So 2017, I'm sure most of us know that ADA released a policy on the role of a dentist in sleep-related breathing disorders. So they're recommending that all dentists screen. So one of the ways to screen is using that Ferris. So it's pretty easy. If you go to the ferris.org, there's other tools that you can use as well to look into that a little bit deeper, if you really want to get into sleep and all of that.
I just did.
And
when you click on it, you guys, when you do that, just to let people know, if they're like me and they were already snapping that QR code, it's going to take you to a OneDrive, which is going to allow you to download it. So if you see something about OneDrive pop up, that's nothing bad. It's just a way that it's like Dropbox, it's OneDrive. So, and they have multiple screening tools. If you go to ferris.org, little slow, their website's like really slow. So if you see it kind of thinking, that's normal, but they have a 6 screening, like a 15 screening, and more complicated ones. But I think that 6 one that you showed us is the best for sure. Simple.
Yeah, pretty simple and fast. But those other ones, if you want to get deeper into sleep and sleep disordered breathing, those are good screening tools as well. Another reason, like I've been talking about, it's just a healthier and longer life for them, for your patients. So this is Dr. Derek Mahoney. He's a big orthodontist. I believe he's based out of Australia, but he lectures and has done many studies on sleep disordered breathing in children and orthodontics, and how you can help airway and breathing through it. So we want to look at craniofacial form. Early diagnosis and treatment of airway dysfunction from birth can really make an impact on them. So this is a good one through OrthoTown. There's a bunch of research articles I'd be happy to share if anybody wants more. I just wasn't sure if I would be boring anybody by just listing.
Yeah, if you can send them to me, that would be great. And that way, if people have questions, I don't want people to spam you too much, you know, but if you send them to me, if they have questions, then I can definitely send it to them. Great.
Yeah, I'll share my folder with you of all the fun stuff that I have, and you can pick and choose what you think is good and not good. I was going through them and I was like, there's so many.
Yeah. No, white papers are good. I think it's a good idea.
Yeah, perfect. Okay, I'll send that over. So why do you need this in your office? Well, it also reduces the amount of time patients are in treatment. So that's what you can think of as well. If you're really wrangling that tongue is in between the teeth and you're not able to close that bite, it's going to be very difficult. You'll take them out and you're going to get relapse. So it decreases the number of relapse, but it also helps reduce the amount of time that you're going to have the patient in treatment, which benefits you and it benefits the patient as well. So that's one of the main reasons from a patient aspect.